Good afternoon, everybody. Welcome to the New York chapter of HIMSS virtual event. My name is Michael Haas, and I am the co-lead of the chapter's programming committee. I'm very excited for you guys all to be here for this virtual event. So without further ado, let's get into this. So for those of you that are on the call, just making sure you guys are all in the right place. This is the Aging in Place Technology and Innovation webinar. Before we jump in and introduce all of our speakers, just want to go over some administrative things. So Dr. Amin, would you mind going to the next slide, please? So we do offer live captioning, which is available. To turn on those closed captions, select captions, subtitles using the CC button in your video controls in case you need to capture the subtitles. As I will be monitoring the chat for any questions that come through. So we encourage all members or all audience participants to ask questions. We do have a panel of questions to go through. However, if we find a question that's in the chat that is timely, we will insert it during the conversation. And if not, we will leave time at the end for the Q&A. So please stick to the end to go through all of the questions. If you run into any technical difficulties, please just refresh if viewing from a web browser. And this event is recorded, so if you have to leave at any point, we will be posting this up within 1 week on our webpage, and there will be an email blast as well. And our YouTube channel, excuse me. Dr. Amin, can you go to the next slide, please? And for those of you that are not part of our chapter and would like to learn more and get involved, we've provided here some email addresses for you to reach out with any questions, or you can scan the QR code on the screen right now and you can join our chapter. As a co-lead in the programming committee and one of our board members, I'd be happy to address any and all questions as we have a great membership. We offer great programs and we'd love to have you as part of the chapter. So without further ado, Dr. Amin, I'm going to pass it to you as you pull up the next slide and we can jump in and start our event.
So I'm going to introduce the panel next. So thank you, Michael. So for that, I need to read their bios. I'm going to stop sharing for a moment here and go to their bios. So the first one is Mr. Robert Blatt, who is the founder of Envoy at Home, an AI company which is at the intersection of aging and digital health, using a patented virtual care system, which he co-invented. It passively identifies seniors' unapparent but clinically important behaviors. He spent his early years in technology and financial services, where he led the design of real-time trading systems for the Digital Equipment Corporation and DuPont Capital Management. Robert graduated from the Wharton Management Program at UPenn and holds a master's degree in computer engineering from Boston University. Dr. Mike Cantor is a geriatrician and an attorney with experience in home-based care models for older adults, his medical specialty, including making house calls for many years. He has been the Chief Medical Officer, or CMO, for technology-enabled health services and digital health companies like Connect America, Matrix Medical Network, and Intuition Robotics, the maker of a digital companion. He also was CMO at Uber Health, Bright Health, CareCentrix, and the physician network of Tufts Medical Center. He trained in internal medicine and geriatrics at Harvard and received degrees in law and medicine from the University of Illinois. Next is Mr. Cameron Carter, the CEO and co-founder of Rosarium Health, which is a platform and service network that enables seniors to age in the community. Rosarium provides them with accessibility home modifications, various technologies, and other home-oriented services. Before launching Rosarium, Cameron spent a decade in value-based care operations, supplemental benefit programs, and business development at DaVita, Bright Health, Evolent Health, and Proven Health Analytics. Interestingly, he began his career in academia, researching the physiological effects of healthcare disparities. Last but not least is Mr. Al Kino, the president of Strategic Interests, which works with health systems, providers of senior living and home care, and other vendors in that space. He is the chairman of the board at the Jewish Home of Rochester, an award-winning senior living community, where he guides strategic planning and innovation and community collaboration. Al also helps other nonprofits, including the programming committee of our New York State chapter of HIMSS, to create events and share best practices in the effective use of HIT. He worked previously for McKinsey, Xerox, and the Kodak Health Group. He received an MBA from the Darden School of Business at UVA. So welcome to our panel's members. We're excited to hear from you today about aging in place. For our audience, the discussion will focus on innovations in both technology and service models in this space. We're going to talk about the increasing use of AI, such as digital companions and remote monitoring or sensing, and about service models focused on seniors. I'll ask the panel members to be brief in their responses because we want to cover as much ground as possible. So with that, a quick introduction to the top. Those were our presenters. So when we think of a senior, we often think of someone who is maybe living with a care partner, a caregiver, maybe someone who is living alone, maybe someone who has one or more chronic conditions, someone maybe in a wheelchair or using a walker, but increasingly we are obviously seeing that seniors work longer, maybe very active, even taking running in a marathon, and they may be living far away from their support network. Seniors may be defined as people who are 60 or 65 or older. They may actually be as young as 50, according to the AARP. If we look at that population of the 60 plus population, it's about 25% of the US population this year. If we include the 50 plus, then that's about 37%. If we look at that population 25 years ago, all right, you see that the 60 plus population was much smaller. And looking ahead, 10 years from now, the 50 plus population is going to be close to 40%. So with that, I'm going to stop sharing and pose my first question to Dr. Cantor. As a geriatrician, please tell us about what aging looks like and the value of aging in place.
Thanks, Amin, and welcome everyone to the conversation. Really looking forward to it. I'm going to share with you a few thoughts about what the implications are of the slides that Amin just shared with us. So the good news is we're getting older. And in terms of numbers, so not just the percentages going up like you saw, by 2050, we're projected to have 82 million people in the United States over the age of 65. That's a lot of people. As of 2022, it was 58 million. So it's not like we're not living already with a lot of older people. The implications of that for today's topics, which focus on aging in place, housing, use of technology to support people's ability to, and I've started to move away from the term aging in place, more to like, how can you live where you want to live? Because that's really what people are after. It's like, how can I stay where I want to stay or move if I want to move? What do I need to do as I get older to be able to do that? there are a couple of things to think about that have significant implications of the aging of our population for housing and our ability to choose where we want to live. One, with the prevalence of older adults comes a higher prevalence of chronic illness. So 85% of Americans over the age of 65 have at least one chronic condition. 60% have two or more. And that's not even that important. Diagnoses are helpful, but not important. What really matters is what percentage of them have functional impairments, the inability to take care of themselves, to move about the way that they used to. And 85% of people over 65, 35%, pardon me, 35%, thank goodness, have with multiple chronic conditions, which is 60% of that population, have disability, which increases the demand for home modifications, for assisted living opportunities, even long-term care and nursing homes. So in thinking about our ability as a society as we get older to live where we want to live, the reality is as we get older, chronic illness disease burden goes up, disability goes up, and our ability to stay where we want to stay, because most people want to stay in their own homes, that is challenged. In addition to that, there's one group I just want to point out quickly that we really have to consider, and that is people with cognitive impairment and dementia. They make up about 10% of people over the age of 65. They actually have dementia. By the time you get to 90 plus, about a third, 35% have dementia, not just cognitive impairment, but actual dementia. Their care needs and costs are much greater, and the burden that they have on caregivers who are trying to help them remain in place is also much higher. And so no matter what we say about people generally, when you think about specific groups of people with disability and specifically cognitive impairment as a type of functional impairment, that's where the real challenges are. And on top of that, the affordability crisis we have in our housing markets across the country. And on top of that, the lack of long-term care insurance, which means that people don't have a way to pay for nursing home care, which is $108,000 or more per year, or for in-home services, homemakers or home health aides, on average, $50,000 to $60,000 a year on top of what you're paying for rent, utilities, mortgages. Even if you own your own home, there's a lot of upkeep, taxes. All of those things add up. And so we face a number of different problems related to disability, functional status, and aging. And technology offers some very interesting solutions. And that's really what we're going to be talking about today, is how do we use technologies like smart home devices so we can communicate with people through video doorbells or motion sensing lights? How do we monitor people's health? How do we enable the environment to enable the older individual so that they can live where they want to live? And how do we use virtual assistants like Alexa or like EliQ, which is made by a company I work with, Intuition Robotics, which is an AI-driven companion for older adults. We have on the panel people with lots of expertise in these areas. And I'm really looking forward to what's going to be a very interesting, rich discussion of how we use these different tools, techniques, and technologies to enable us to live where we want to live as we get older.
Thank you, Dr. Cantor. I'll move on to ask Al, then Cameron and Rob about what Dr. Cantor just mentioned in terms of challenges that seniors face when they desire to age in place. So, Al, what else in that space?
Sure. And so what else? He gave a pretty good list, but if we want to come back and take another view at it, there's a need to be helped with just the activities of daily living, the ADLs. Some people are struggling with those, and if they can't handle them for themselves, they're going to need to have somebody to help them with that. Medications. So medications are a real problem, and being able to know what medications to take, being able to take the right meds at the right time, and sort of document or at least be confident of what was taken. Access to care. So people can't get out of their house and go to appointments. So they either A, need to get transportation to take them there by a loved one or a service, or B, they have to somehow become facile and capable of using telehealth and other capabilities to be able to do so. The disease management, the unique aspects of if you have one or multiple chronic diseases, that just compounds the things that you have to do to care for yourself. So some struggle with being able to understand how to either be able to address the conditions that they have or the symptoms that they're having or what they have to do to be compliant with the direction that they're getting. which is related to the next one, which is just understanding what they're supposed to do to be able to be healthy and live a good life. Separate is the whole notion of the social challenges. So socializing and not being isolated in their home. One of the biggest problems people living at home is actually that, and being able to engage with others to make them feel better. So hope that's helpful.
Yeah, thank you, Al. Cameron, I'll go to you next. John, yeah, challenges for
Yeah, I would
seniors.
say a lot has already been addressed. One that I think a lot about is awareness of services. I think as more departments of aging, more social services become available, there's a accessibility challenges around just getting access to some of these services. I think like for us with Rosarium Health, we do a lot of work with home modifications. New York State now has a $10,000 lifetime allowance for home modifications, and as of December, they didn't have one. And there's about 14 other services are now available for those who are on Medicaid, those who are dually eligible, to be able to take advantage of it, not only live age in place, but age, with grace in whatever community they want to be in. I think the other is affordable solutions. Dr. Cantor spoke a lot about the affordability crisis we're going to run into. I think a lot about wealth inequality. We do a lot of work in rural parts of this country where a lot of folks are worried about outliving their finances, outliving their net worth. So being able to be mindful of not only just putting great technology, but also affordable technology in the hands of a senior population that, for what it's worth, may thought that 70, 75 was kind of the end. Now you're thinking about 95, 100, 110, and a lot of those pensions and a lot of those stocks and things like that weren't really prepared for that. So as you think about what does it mean to live, we use the term third act, which is anything over the age of 65. That could be 40 years for some of these individuals, and it will be. So being mindful of affordable options is going to be critical, but also being mindful of just what is already available for these individuals is also critical, as well as you think about what folks want to do in that third act of their life.
Thank you, Cameron. Rob, anything else in terms of challenges?
Yeah, we've covered so much. I think to sort of put a slightly different spin on this, it's really the idea of assessment of risks. And what I've noticed is that both care recipients, our older adults or seniors, and their caregivers are really poor assessors of risk. It's probably not surprising. And so it's almost like when we think about, I think, as Cameron pointed out, this third act of your life, when we're in earlier parts of our life, we recognize the need to, say, baby-proof our home and the importance of not letting, for example, like a child live alone. But when we come to our later stages of life, we don't necessarily think about the changes that we have to make in our home to allow us to live safely, to preserve our wellness. It's almost like, this idea of Maslow's hierarchy of needs. And we'll talk a little bit more about that later, but there are various things that we need to promote safety. And as poor assessors of risk, it can certainly significantly jeopardize one's ability to live independently. And it has a profound impact on the financial implications. I think, as Dr. Cantor and as Cameron and as Al have previously mentioned, we really don't talk about and plan as a society the financial impact to that third act, as Cameron talked about. And there's been a lot of really phenomenally good articles in both the Wall Street Journal and the New York Times recently that talk about how families are being just bankrupted by the costs associated with that. And I think with some planning, and technology can certainly help, there are strategies that allow older adults to mitigate some of these concerns. And I'm sure we'll get into that as we go, but I'll just stop there. So it's this idea of risk, and the financial implications are just so profound.
So actually, I'm going to stay with you, Rob, and elaborate more about how caregivers fit into the picture of aging in place, because that's an important piece of it.
Yeah, and I don't come from a medical background. We have folks on our team who bring this perspective, but it's this idea of the healthcare dyad, the caregiver dyad. The caregivers in what we've discovered are absolutely vital to the success of living independently as we age. Just absolutely vital. It's, if you remember back when we all took the SATs, on the vocabulary section, there was this idea of necessary and sufficient. It's necessary to have a safe home. It's necessary to have all these kinds of things. But success and the sufficiency has to do with caregivers. And without that synergistic or almost symbiotic relationship, there's very little opportunities for success in terms of long-term care. And so one of the things that we work on is how do we bring in caregivers into the conversation every step of the way, so we can spot risk, we can mitigate, we can provide additional support, and we can help them promote interventions, medical interventions, clinical interventions as well, by bringing data to the doctor, uncovering what's happening for all those hours when care recipients are generally left alone, which in many cases is over 20 hours. So we think about that, caregivers as just absolutely foundational in this third act, as Cameron was talking about earlier.
Great, thank you. Al, your work and the services and interactions you have are in a different setting other than the home. So again, same question, the caregivers, how do they fit into that picture?
Sure. So first of all, there are two broad categories of caregivers. There are those that are lucky enough to have family that can help, are lucky, not everyone does. And I'm not so sure that the people that are the caregivers would always consider that lucky, because it's quite a bit of stress and it changes their lives. But, it depends on the family versus not, and also depends on the funds that are available, that might be available. As board chair of Jewish Home, we've had a mission for a very long time of taking care of seniors in the institutions in which they are. It started as long-term care, skilled nursing facilities, added to that assisted living, added to that independent living. And then, of course, now we're acknowledging that the world is going to change and is changing. So offering community-based services. And we have a robust and constantly growing set of services that are available to people to be able to stay in their home. Some tend to be funded by the federal payers, CMS, Medicare, and or Medicaid, but increasingly others are only available for private pay. So the reality is the system is about to implode, and the government's going to have to realize it needs to do something. So we're going to have to find a way to get the hospital in the home. There are not enough beds in hospitals, and the skilled nursing facility in the home to allow people to age gracefully at home. So the role of the caregivers are going to be personal care and meds and transportation and running errands and talking to doctors and being able to decipher what's necessary, advocacy with insurance and other problems, environment and setup. So make sure there aren't things that can cause falls and tripping over things, cleaning and companionship. Those are just some of the things that need to be addressed somehow.
And I would just
Thank you,
add to
Al.
that, if you don't mind, if I could just jump in
Yeah,
for a second.
go ahead. Yeah.
So I was privileged to be my mom's caregiver for a long time. She passed away a couple of months ago. I have 3 siblings. My mom lived in Kansas City the last couple of years of her life, where my brother and sister live. I have a brother in Minneapolis, and I live in Boston. And it was a major focus of our life to help her live her best life. And she went through the process of living alone, living in the house I grew up in, then living in a condo, then moving to assisted living. Then for the last year of her life, she lived in long-term care. And each of us, we were lucky. There were 4 of us. We were lucky that we all kind of agreed on the general idea for care. And she was supportive and told us what she wanted, and we helped to enable that to happen. But it's an incredible amount of work for caregivers, as you pointed out, Al, to make sure that the loved one is getting what they need. And I think it's important to remember that just the communication and collaboration, which is where our healthcare system today suffers a lot. It's almost impossible to get a hold of anyone who has the ability to give you answers you need when you need them about your health, and regardless of your age. But when you have a frail older person with multiple chronic illnesses, that challenge becomes even more evident. And from a geriatrics perspective, what I point out is that there are two sort of broad categories of needs that we think about. And they're based on understanding our activities of daily living, or ADLs. There are two categories. There are the instrumental activities of daily living and the basic activities of daily living. And the instrumental activities of daily living are the things you need to stay independent in the community. So it's paying bills, taking your medicines, some of the things we've already discussed, transportation, being able to buy your groceries, all of that stuff. And caregivers today play a huge role in all of those areas. And as my mom's health deteriorated, my family and I stepped in to do a lot of those things for her, the paying the bills and transportation, all of that. And then there are the basic activities of daily living, which are the things that you need to do just to stay alive. And what we know about them is that you lose them kind of in reverse order that you gain them. So when you're born, the first thing you do is eat. Then you learn how to move. Then you learn how to go to the bathroom yourself. Then you learn how to dress yourself and bathe yourself. As you get older, in general, you lose that support in reverse order. And so the needs to stay in the community, if that's where you want to live, usually it's the instrumental activities of daily living that tend to go first. And then as the impairment proceeds, you see more loss of the ability to take care of yourself. And caregivers who do physical care, hands-on care, we know that's a much tougher job, physically tougher. And many caregivers themselves, like, are not in their 20s, right? A lot of us are middle-aged. And in many cases, the person who's taking care of the older person is themselves over 65. And about a third of them will actually pass away before the loved one that they take care of. And so if you think about what do we need to do to allow people to live where they want to as they get older, it's going to require a lot of support for caregivers because we can't afford to pay for all the services that the caregivers provide, and strategically thinking about what Rob said about assessing, identifying where those challenges and where the resources, whether it's informal caregivers like a family like ours family did for my mom, or is it something that's paid for by the government or by your private long-term care insurance or some combination. And technology plays a role potentially in each of those different categories of instrumental and basic activities of daily living.
Thank you. Cameron, you work with families all the time. So anything else to add about the caregivers and how they fit into aging in place?
Yeah, I think one of the things that we have to be mindful of is that caregiver is such a broad age spectrum. And what I mean by that is, we do a lot, and I mean, this is not so much around sort of this band. We do a lot with children with special needs, where the caregiver is actually in their 20s or 30s. And then more specifically now, it's the grandparent taking care of the child. So having this sort of bidirectional idea of what a caregiver's age could be is really critical as well, because, to Dr. Cantor and his siblings support of, their mother, I mean, they also have lives as well. They're also caregivers to whether they have children or they have other dependents. So when I think about sort of this opportunity moving forward, it's that burnout can be a lot of different things. You hear the term sandwich generation a lot for Gen X. I would have to say baby boomers have been experiencing that sandwich generation for about 2 or 3 decades at this point. And it's one where now, as you have the first Gen X population turning 60 this year, it's something that's going to be a lot more of a, I don't know, burden, but more of a talked about burden, I hope, because we need solutions. We need more communal living. We need more sort of societal, support. And think about the term, I think it was Alec brought earlier about baby proofing a home. It takes a village to take care of a child. It's going to take a village to take care of a lot of older adults. And for a lot of folks may not have, siblings around or family nearby. It's going to take a lot of neighborhood support to really support these individuals as well.
Thank you, Cameron. Michael, are there any questions about this first part to kind of set the stage to talk about technology and innovation? Any
Not
audience
yet.
questions?
Everybody
Not yet.
has
Okay.
been really interested, and some folks had to drop, but so far, so good. So keep it up.
Okay.
Thanks, everybody.
All right. So, Cameron, I'll stay with you and ask you about technology, with or without AI, that fit into this concept of aging in community or aging in place, and what kind of needs do these technologies address?
So for us at Rosarium Health, we always tell people we're blue collar innovation. I mean, we go in, we assess homes with clinicians in anybody's home. We send contractors into homes. We break walls, open doorways, put ramps in people's homes. So the technology for us is actually just streamlining fragmentation. removing that concern as it relates to how can I ensure someone gets home from the hospital sooner, gets out of a SNF or other types of high cost institutionalized care center with our technology. But the one piece that we're seeing a lot of that gets missed is assisted technology and assisted devices, whether that's smart home technology, not just so much Ring doorbells, but smart sprinklers, smart thermometers. Another thing we're starting to see a lot more is weatherization. So we spend a lot of work right now in California where it's becoming a much bigger concept around how do I have cleaner ducts? How do I have cleaner air quality for myself and my family? But we also see it a lot in, let's say, the coastal areas, like in Texas, where people are asking, how do I get heaters into my home because of the Texas freeze, like you saw in Dallas about 3 weeks ago? Those are a lot of technologies that get a lot missed. But what I can say is that assistive technology is actually covered in Medicaid in most states. That's again going back to the access and the awareness where you have in some states up to $20,000 over 5 years to pay for this type of technology for dual eligible members and Medicaid recipients. However, when I think about where technology is going to go, it really comes down to what's the goal of the person? What's the goal of the caregiver? We don't want to just put tech in people's home because it looks interesting. It should be, considered, does it improve ADLs, IADLs, or quality of life? So, though we do put a lot of, physical property into homes, DME into homes, we're also mindful of what would be the last thing is really this digital divide. We go into a lot of homes, people don't even have the internet. They don't have enough broadband to even do telemedicine. And then people are saying, well, why doesn't this person do my telemedicine visit? And it's like, well, they only have 25 MBSs, broadband. They can't do anything on Dr. Demand or telemedicine. So I'm mindful of the digital divide. I'm also mindful of over technology into people's home that doesn't really, solve anything sometimes. We're also mindful of there's a lot of funding out there for technology into people's homes. And I would just hope that more people are aware of it, including both patients, caregivers, physicians, and those who are able to support patient populations.
All right. Thank you for that. Rob, I'll go to you next, talking about technology serving seniors.
Yeah, so I recently just returned from the Consumer Electronics Show, and the AARP has this big age tech pavilion, and Samsung Health was there, and we were sort of part of all of that. And there is a lot of technology, and I think, and it's in one hand it's very exciting, and another hand it's also very fragmented. And with all that said, payment models just simply don't exist. So when we talk about equity and things like that, a lot of this comes down to private pay. Having said that, when you think about I think Mike was talking about this earlier in terms of IADLs and ADLs, and even using more of a sort of a medical term here, and I'm not from that space, but this whole idea of acuity, the question is, where does somebody fit in those dimensions in terms of what problems you're trying to solve? And so there are some really exciting solutions just around these augmented reality goggles to put on, and you can travel to all over the world and have live tours very easily. These are now showing up in senior communities, and they can show up in homes as well. And so there's that level of technology that addresses social isolation. And then there are things like what we're doing, which is around this whole idea of safety and wellness, which is the idea of creating this concept of a digital twin. See, we think about smart home not so much to make the home smarter, but how do we make caregivers smarter? How do we give them information? And particularly, as we were talking about earlier, the explosion with dementia, you have patients who can't really speak for themselves. They're really poor assessors. They can't even communicate, their own needs. But if we can create this idea of a digital twin, a representation of what's going on in their behavior, now we can really open up an opportunity to provide really much, much, much better care. So there's an entire spectrum. There is a lot going on. It's very fragmented. And there's some work that, for example, Samsung Health is doing with this project Care Hub around how do you create the digital front door and things like that are really very exciting. And we can sort of double click more into that, but I'll stop there.
Actually, I'll ask you maybe to elaborate a little bit more about using AI in sensing and behaviors and helping caregivers and the senior.
Sure. Yeah. So if we can uncover what the patterns are during the day, what time people are going to bed at night, what time they're starting the day, if there's signs of wandering, elopement, changes of toileting, wandering, nutrition, medication, all of those kinds of things can now be captured in this idea of a digital twin, which is just a digital representation of somebody's. Really, it's based upon their behavior, and it be captured in real time daily, which is just incredible. Now think about this. Let's take a generative AI and let's empower anybody, just a clinician who doesn't even know a patient, where you can ask questions that says, I'm taking I'm taking mom to the doctor later to visit her doctor. What are the important concerns that I need to know, and get a very easily understandable assessment on all of those dimensions around, the idea or the ADLs, which is just an incredible way to understand where the risks are, where to provide more support, where there's opportunities for intervention, and look for very subtle changes in behavior, which are often the early warning signs that someone's acuity is changing, whether it be around UTIs, it could be a discharge and a change of medication, it could be anything. And we're, to be able to provide that data and provide solutions like that is available today, and it's incredibly low cost.
Thank you, Rob. Al, I'll go to you next about talking about technology with or without AI. Michael?
No, Pat, before you jump in, Dr. Amin, and Al, maybe we'll take this, but Rob, just because you were talking about the conference, we did have one question in the chat that was asking around what are some of the most proven and effective technology solutions that the panel has seen working in homes and or assisting those caretakers. So you were mentioning the AI or mentioning Samsung. Is there any other solutions perhaps for you, Rob, or others on the panel that could address this audience member's question?
I would ask
we want to fold that as part of the question about technology here. So Rob, finish what you're saying. And
yeah, I would ask the person who wrote the question if they can perhaps, because there are really so many proven technologies. I mean, everything that was in AARP is proven, and I would just ask the questioner if perhaps there was one particular dimension, area, aspect that they would specifically like us to comment on.
So Al, take it away.
Sure, and it's related to the AI aspect of it, but agreeing with Rob, you can apply the tech in so many different ways. It's sort of like saying, where do you want to use AI in healthcare? There literally are too many. Which problems do you want to solve? Fortunately, you can use tech to help address things ranging from enhancing compliance to meds, to monitoring the environment, to understanding how an individual is behaving, perhaps, and identifying where their risks are of who potentially could be sliding, especially if you're going to be pulling information out from the EMR. But it's not really limited to that. I mean, we have seen just the notion of being able to keep somebody at home, and core telehealth is one thing. It's became easy because of COVID, but adding to it, remote patient monitoring is probably as reliable now as a technology as there is. And not only that, informative, because those that have chronic diseases, it'll be an opportunity for the nurses and or the providers that are caring for those patients to know how they're doing, if they're still within normal limits of the diseases that they have, whether it be blood pressure or glucometers, et cetera. So that's probably one of the most relevant ones. Combining the two of those makes it even more powerful. But it's also moving into areas like home-based therapy. So somebody mentioned the virtual reality. Being able to take somebody out of after a surgery, getting home instead of going to a nursing home. A lot of people are now going directly home, musculoskeletal surgery or a stroke. They have to go through a pretty serious rehab regimen. And those rehab regimens require getting a patient out of the house and into a facility, especially if you live in the Northeast with this winter's weather. It's been terrible. Being able to allow an individual to do that at home has tremendous promise. It's still on the frontier side, but once it becomes more commonplace, I think is one of the things that has an opportunity to revolutionize care. Not only that, there are not enough therapists. So, and direct labor. So, being able to find a way that tech can be applied to reduce the reliance on direct labor is going to help the institutions that are trying to serve individuals. So, I would say those are a couple of other things that would be worth considering.
Great. Dr. Cantor, yeah, I want to go to you, regarding the use of technology and, but as you
Sure.
answer that, you've also been on the payer side. So I want you to kind of fold into that as well. The question that was raised about proven, because I don't know if that the person who asked that is, um, comes from a payer side, provider side, for have a senior at home and finance background. So please go ahead.
Sure. So I work for a company called Connect America. They have about 500,000 people across the country on personal emergency response systems. These are the buttons that you push when you fall down. It can be on a pendant around your neck. It can be on a wristband. They also provide remote patient monitoring that Al mentioned for physiologic, so heart rate, weight, blood sugar tracking through glucometers, oxygen saturation in the blood, all that stuff. And what's really interesting to me is that the personal emergency response systems are 50 years old. That technology is 50 years old. It works. You push the button, you're connected to a call center. Someone asks you how you're doing. If you can't answer, they send someone out to help you. If you can't answer, they help figure out, do you need to go to the emergency room or not? It just works. The remote patient monitoring, the sensors of physiologic parameters, that's a technology I've been working on for a long time, over 20 years, trying to figure out how do we monitor people with diabetes and heart failure and depression. You can use the technology in a lot of different ways. But what we really need isn't either or technology. In the home setting, what we need is a network of sensors that's tailored to the needs of the particular individual and their risks. So it could be ambient devices, I think that Rob, that you're thinking about. So sensors in the wall that know that I fell down. I don't even have to have a button that I'm wearing. It just senses that fall and sends a message, or it notices that my behavior has changed. The UTI example is always the one, at night I get up at one time to go to the bathroom. Now for the last 2 nights, I've been getting up 3 or 4 times. What's going on with that? It doesn't make a diagnosis, but it raises the question, and someone has to reach out and say, oh, what's going on, Mike? How are you feeling? So building that network of sensors in the home, filtering out the noise, the signal to noise ratio is critically important. That's where the proven problem arises, I think, with a lot of remote patient monitoring, is knowing that weight gain isn't, I decided to jump up and down on my scale or it broke, but actually that my weight's going up because my heart failure is poorly controlled, and someone better call me and tell me to adjust my medication so I can take that fluid off, or I'm going to end in the emergency department next week or maybe even tomorrow. What's interesting to me is that we don't have payment models that cover that whole network of sensors. We have Medicaid pays for the personal emergency response systems in almost every state. Medicare pays for the remote patient monitoring. Medicaid does some of that too. No one pays for the sort of environmental sensor. No one's paying, but I mean, I work with Intuition Robotics, makers of LEQ, the companion robot for older adults. It's what I would call a conversational sensor, because it asks you, how are you feeling today? And it remembers, if you say, I didn't sleep well last night, it'll ask you that afternoon, do you think you should take a nap, or how are you feeling? It learns about you and uses that knowledge about you over time. In New York State, the Department of Aging is paying for older adults all across the state to have access to LEQ and getting great results in terms of reducing loneliness and isolation. But we don't have a common payment mechanism that covers all of the different technologies that could benefit that person. And so that's a huge stumbling block, because what it means from a provider of technologies perspective is you've got to find private pay and maybe some Medicaid and maybe some area agency on aging funding, and that can come and go, and Medicare covers some, and Medicare Advantage plans, they can choose to cover some things differently than typical Medicare covers. So some of them will pay for personal emergency response systems, some of them will not. But the interesting thing about all of this is the technology is beginning to merge together. So today, the company I work with, they make a wristwatch which has a dedicated button on it that if you push that button, you're automatically connected to the call center. It also has heart rate sensing. Someday we'll have oxygen saturation sensing. It also has fall detection in it, which means that if I fall down, I don't have to push the button. It sends that signal to the call center and they call me. And that's, by the way, true of all dependents. You can get them with that built in. And we know that people underreport falls. Falls is one of the greatest risk factors for not being able to stay and live where you want to live as you get older. So having these devices and seeing them begin to fit together, or the use of more ambient devices that are just sensing things, you don't have to wear anything or put it on, that will continue to advance. That is going to enable us to get much more data, whether it's a digital twin or just observing what's going on in that home. That's going to be where I think we're going to see breakthroughs in the next 5 to 10 years. And in the meanwhile, we have to figure out who pays for it, how do we pay for it, and that requires more data, more proof about the value to whom of these technologies.
Thank you. So a couple of concerns were raised about access. And I think there are definitely disparities in access to these services that Cameron and others alluded to earlier. Going back to you, Rob, regarding the concerns about the false positives. And so I'll go to you first. You know,
Yeah, that's something. So to Dr. Cantor's point about ambient sensing, that's essentially what we set up in about an hour in people's homes. This idea of creating off-the-shelf sensors and turning it into an ambient sensor that's personal, hyper-personalized for care recipients. And so this idea of false positives is a big issue. And one of the areas where we have intellectual property, in fact, where I have a patent, is in this area about this behavioral sensing. So we don't really look at for us, the actual sensor data is not that important. It's the behavior data. And our secret sauces, if you will, is how do we go through that translation around converting a sensor data, which is an event. Humans exhibit behaviors, so we really care about that, and we're really proud of that work that we've done to minimize these false positives. So for us, it tends not to be an issue. In fact, one of the things that people discover is that they learn very quickly whether or not mom or dad can live independently and they can continue their journey, or perhaps that they're exhibiting signs of, safety risks by wandering or elopement or whatnot. So it is a real issue. We've are proud of the work we've been able to do to be able to tailor that experience around. Do you want to be notified to confirm something happens? Do you want to be notified if there's an exception when that something happens? And all of that is very tailorable. And the idea of using AI or ML, machine learning, to figure out what's the normal pattern for the care recipient, we get asked this a lot. And I think early on, it was a misguided approach. We don't want computers to decide what is normal for a person, particularly as they're exhibiting cognitive decline. We want clinicians, we want humans, we want people to make a determination of whether or not this behavior is normal and is acceptable. And when we start seeing, we want to be able to highlight the deviations, and we want to be able to use AI to help people really to make these determinations. So that's how we think about it in a nutshell. And I think that's the direction where I think the industry is headed, and we continue to move in that direction as well.
So I'm realizing we may have audience questions. So maybe in 30 seconds or 20 seconds, Al and Cameron, anything else regarding concerns that seniors or caregivers may have about the use of technology?
I'm going to flip it around, and I'm going to say the organizations that are deciding where and how to apply it need to consider where can it add the most value. You may be early on, it may be experimental, or you may be using proven technologies, but two aspects need to be addressed. One is that the user in the house may not have the capabilities to actually utilize the tech, however minimal it is. I help care for my mother. she can't even text. So it's very important that don't bother trying it with people if there's not somebody in the house that can help. And second is, it's not just implement the tech and hope for the best. Those that have either nurses or connection to care teams that can help utilize the information, as Rob was just saying, is far more likely to be successful than putting the tech in and hoping for the best. So,
Right. Cameron, in 20, 30 seconds, anything else about technology, concerns regarding technology?
I would just echo everything Al said. I mean, I think it's important to realize that a lot of the people who are building technology, they're not the users of their own technology. So it's mission critical to not only do market research, but continue to do market research. And older adults are not a monolith. So just because someone's over 65 or 67 doesn't mean they're the same 67-year-old person. So be consistent with that customer insight, be consistent with, for instance, Al's mother doesn't text. My mom texts all the time and I wish she didn't. So it's like, sometimes you have this sort of like spectrum you have to be appreciative of because the users want that appreciation as well.
Thank you. Michael, any questions?
Yeah, no, I think first off, everybody's been acknowledging that this has been super helpful, and especially around the payers. I'm glad we went down that path. Another question around, patients and citizens at home, is a known preference for individual. However, what are the views on technical maturity in care and residential homes? Al, you hit on remote patient monitoring, but to ensure the full patient record is visible and available when required. Are any technologies jumping into patient records and making it available for those, providers perhaps that, from a coordinated care perspective?
well, the home care provider, if it's a primary care doc who has access to what's happening in the home, that should be the hub of the electronic medical record, and all other things should feed into it. If it's a home health agency, they usually have a slightly limited view, but they'll be better able to meet the needs of those individuals if they have broader access to everything that's going on with the patient. So the integration between the home health record and the primary care record will be absolutely important. And then regards to adding the remote patient monitoring or other vitals or other elements that are part of it, that integration will allow either individual to be able to be more successful. So that is a key part of it. And a patient portal, I forgot. So everything is much better when the individual and or their caregivers utilize their patient portal to make sure meds are current, to make sure, and if anybody happens to have an app that is including patient-reported outcomes to supplement what Rob said about the environmental data and what Mike has said and Cameron, that would be awesome. How are you feeling? What are your problems today?
So there actually are solutions like that, Al. I talked about the robot, but there also are text-based, basically chatbots. So Connect America has one called Esper, where it will actually help the older adults set up the technology in the home, and you can use it to check in on, did you take your medications? How are you feeling? Et cetera. So you can look at all different levels of technology and sophistication in terms of machine learning and artificial intelligence. What I do want to think is important, I wanted to add, is that, and it's in the chat as well, privacy and safety are a huge concern for older adults. I once wrote a paper many years ago about monitoring technology in the home, guardian angel versus big brother, because I think it can be either, depending on what you're using the data for and how secure it is. It's really a problem if people know exactly where you are at all times in the world we live in today. So you need to balance access and sharing of data and integration, like Al was just talking about, with the protections to make sure that only people who need that information can access it, and to empower the individual to decide who those people are. No information about me without me. In other words, don't give people access to information without getting consent from the people who are being monitored.
I think that's a really good response too, especially or Rob, you were going to add something?
Yeah, and then as we talk about AI, there's this notion of hallucinations and having the proper guardrails, and that's a real issue. And it is something that anybody, if you have any kind of AI chatbot, you have to pay attention to it. It's very easy for these things to completely make up information, and also you have to be very careful that it's not trying to render a diagnosis. So in addition to the standard privacy and data privacy kind of issues and access and consent. We now have sort of a newer set of things we have to pay attention to. And generally, those who are responsible are, there's no question they're thinking about it, but it really does need to be on your radar screen, certainly for any solution provider.
I would
And a
agree with that.
user too, yeah.
I think that's a great segue, because the next question that came in was more around the regulatory changes. So are there regulatory changes pending, especially with the new administration, that might help accelerate change and tech availability for seniors in the new year? Like, is there any FDA rules or OTC hearing aids, anything like that that we need to make the audience aware of?
I can jump in real quick. A lot of the Medicaid home and community-based services policies are on the cookie cut, and that's going to play a really meaningful role in assistive technology, home modifications, particularly in red states that are on very tight Medicaid budgets. We spent a lot of time in California, New York, Illinois, just because that's where we've seen success in adoption. But we also serve PACE programs, area agencies on aging in the Midwest, where this is a very serious concern. This is not just about nursing homes being more expensive or more home care services being more expensive. So I'd really pay attention to not just the Medicaid 1115 waiver policies that may be, affected, but also the HCBS services that have been around for about 4 years that really support social determinants of health, social care gaps, but also play a meaningful role in helping to socialize seniors in given areas. So that's one thing that we're paying attention to and tracking for this administration, because I think it's important to realize that a lot of seniors are already on Medicaid. It's not that it's going to be growth, but it's a lot of people are already utilizing those services for a few decades now.
I wouldn't mind adding on to that, Cameron. So as Medicaid goes towards value-based payment, they're going to need ways, and PACE programs are awesome, because that's when you're going to get, how can we lower the total cost of care? And it's going to require not individual, people want to get paid for the tech or the service that they do, the fee-for-service model, which can afford some of what we're talking about. But this major change, SNF and hospital in the home, is not really going to happen until we have the ability to do that. And the question about HIEs is very related. We did a project, I think it's 8 years ago, on improving transitions of care from hospitals to nursing homes to the home environment, or directly from the hospital to the home environment. Without accurate information, the transition of care is not going to be successful. Also, proactive HIEs are also receiving data from the home health environment and making that data available to the primary care doc, who's trying to keep their eye on the patient-centered medical home version of how do we keep that patient cared for. So there are plenty of opportunities to enhance home care with the HIEs if your local HIE cooperates. So.
Michael, any other questions? We're at the
That-
top of the hour.
Yeah, no, I think that's a good segue. I'm just checking to see if there was anything else.
I can ask a question maybe to the group here, and there are a lot of startups in this space and lots of new technologies, some of which will fade away. Most startups fail or kind of exit within 2 to 5 years. So what advice would you have for anyone on the event here today who is tackling or has some new technology in this space, or is interested in getting into this space? How can they succeed?
So I think the biggest challenge that startups face is product market fit. In other words, figuring out whether whatever it is that you do or provide meets a specific need in the market, and that people are willing to pay for, or there's a mechanism to pay for whatever it is that you're providing. And so paying a lot of attention to what your customers are looking for, understanding the older adults, their caregivers, the local professionals, the clinicians, the policymakers. What are they looking for? What do they need? What can you actually get into the community as quickly as possible? That's really important. And I would ask Cameron to comment on that in just a second when I'm done, because I'm sure he's living through that every day. And the second thing I would say is we need more places to test this stuff. And that's kind of on us. We don't have easy places to go. I have a great idea for fall prevention. I want to go and work with an aging services provider that has independent living, people living in nursing homes, people living in assisted living, to see if I can test in these different areas, this model. We just lack that sort of structure and ability to easily facilitate the testing of innovation in a rapid way to figure out quickly, does this thing have legs or not? That's something else I would challenge people to think about, is how do we build that kind of capacity looking to the future?
So we can go to Cameron, maybe first, then Rob, to add to that, or we can go to Rob first. Which one?
Cameron, go ahead.
Yeah, just as a startup founder and first-time founder, those testing grounds are critical. I think the place that we saw a lot of success were independent home health providers, who it's like a mom and a married couple has like 10 people, and they're like, let's just try out this Rosarian product and see if we can modify these homes. And that product market fit allowed us to understand what didn't work. And for us, we started in Medicare Advantage, we started in older adults, and we found our sort of success in Medicaid because there was just really no competition. Now the adoption is a challenge because now it's young adults, children, older adults, but from a growth standpoint, it's helpful for the business. However, we've seen a lot of success in area agencies on aging, cold calling some of these folks, and just really being mindful of kind of that grit. But innovation is needed, but it needs to be tested. Just like the technology, you never know where people can utilize or not. So yeah, I think it's important to test things early, often, and not get so caught in an echo chamber because you're a founder and you think everything you do is great. It's like your own baby. So.
And if I can just add a different dimension, all of that is all very true. And as a first-time founder, you have to struggle through all of those things. However, I think many of the reasons why a lot of companies fail is because of distribution challenges. There's 48 million unpaid family caregivers out there, right? The question is, how do you reach them? Because most people don't self-identify as a caregiver. There's really no good marketplace. There's really no way to really access large pools of caregivers who are struggling with these challenges. Buying Google ads will bankrupt everybody, certainly in this space. And so that is a very, very important hurdle to address, is the distribution piece. Once you get the product market fit and so on and so forth, it's this challenge of distribution is a real issue that most, I think, entrepreneurs don't quite think about early on. They think about the product, but it's really, at some point, we got to sell it.
Thank you, Rob. Michael, is there one last question?
There is one last question, and I do encourage any of the audience members that have follow-up questions after this to please reach out to our panelist members, or please reach out to the chapter. I'm happy to facilitate any connections. And before we get into this last question, panelists, thank you so much for volunteering today and sharing your knowledge. We have a new administration underway. We have a bunch of different volatile, I'll say, things going on in the industry. So it'll be interesting to see if we had this conversation again a year from now, what would have changed. You mentioned technologies, you mentioned regulations, you mentioned a few other items, which I think is great. And I think it's a very timely topic. So I'll come to Chris's last comment right here. And he asks to you, Mike, he's like, as a CTO in a CCRC that is actively looking to help and test and develop new solutions, where should we look to make ourselves available as a deployment partner? Or development partner, rather. Yes, development partner. Thank you.
Yeah, well, first of all, great. Happy to talk to you offline if you want to get more specifics. And I think you all have access to my email address after this. Feel free to reach out, or I'm also on LinkedIn. What I would say is that attending events like this, going to places where you're going to find innovation and incubation of digital health startups and aging technology startups is a great place to go. So already we heard about the AARP Age Tech Collaborative because of the great work that they do. That's all available online, easy to access, great group of people. The CCRCs are welcome to join that, actually, as participants of the AARP Age Tech Collaborative. In New York City, there are a number of health information technology. HitLab, I think, is one of them that does technology acceleration for digital health companies. There are a whole bunch of Y Combinators and digital accelerators all over the country that are relatively easy to find using AI like ChatGPT or Claude or whatever your favorite, Genesis, et cetera, but there are plenty of places to hunt for innovators who will look for you. Depending on where you are, there may be hack healthcare or hack aging events where you can go and say, I'm from the CCRC. We have people in all different stages of housing and would love to innovate and figure out how to do a better job of helping them stay healthy and stay functionally active. Who wants to work with me? So there are plenty of places to go where you'll have lots of people happily call you and reach out to you. I think there's also an international association of business incubators that can help in terms of thinking through the infrastructure that you need to get the maximum value from these experiments, if you will. You need to think about the data gathering, you need to think about the metrics, you need to think about the length of time, you need to think about the funding. You may need to think about, if it's research, institutional review boards to protect the people who are participating in the research. Even if not, if it's just quality improvement, you might still want to affiliate with an academic institution that can help you with grants and with IRB and with quality improvement reviews and things like that. So it's probably a topic for a whole other webinar.
It is, and I hope
Yeah.
you don't mind. I'm going to
Please
sit
do.
in on that. I'm going to sit in on that conversation as the board chair of the organization where Chris works. And you just said a mouthful. We're going to have that conversation and see if and where and how a lot of your expertise can help sort of hone that in. And I also would like to thank HIMSS for the opportunity to make this session a reality. So.
Thank you to the speakers here, presenters, for what you shared with us today. There's plenty more we could cover. I'd like to thank the audience and those who stuck with us for the extra several minutes. If you like this, we do this every month, this sort of event. So the chapter is very active there. And if you like this event and want more about aging, do let us know as well. So with that, I'll hand it over for the closing remarks.
Again, everybody, this will be up on our website and YouTube channel within the next week from a recording standpoint. Please, again, feel free to reach out to the panelists directly or through me if you have any future questions. Any feedback would be great, too, to learn more about this industry for future events. And also, if you're interested in being a panelist, we would love to have you. So with that said, thank you, everybody, for your time, and I hope everybody has a great day.
Thanks again, everyone.
Thank you.
Have a great day.
Thank you.
Bye-bye.